Hello, everybody. My name is Jeehon KANG, and I'm from Seoul National University Hospital. It's a great honor to speak at the EBC 2021. It would be much more better if we could meet in person, but I will do my best to give my message on Zoom. The title of my speech is The Impact of Clinical and Lesion Features on Clinical Outcomes After Bifurcation PCI. This was an analysis that was done on the BIFURCAT registry that I will explain during my speech. I have nothing to disclose. Now, regarding bifurcation PCI, there has been an increase in the bifurcation PCI, especially for left main PCI. And along with this increase in bifurcation PCI, there has been an improve in clinical outcomes. This is probably due to the improve of PCI techniques, the improvement devices, optimal patient selection, and sophisticated medical treatment for the bifurcation PCI patients. However, despite this advance, bifurcation PCI is still associated with a lower procedural success rate and worse clinical outcomes compared to simple PCI. Regarding the optimal treatment strategy for bifurcation PCI, there has been a couple of scoring systems or criterias. First is the resolve score, which was studied to evaluate the risk of side branch occlusion. And second was the definition score, which was a systematic criteria which could guide the optimal stenting strategy. However, we could see that all the factors that were included in these criteria or scores were angiographic or lesion-related factors. However, we all know that it's not difficult to appreciate the fact that clinical factors is very important in determining the clinical outcomes in the patients that we treat. So especially in bifurcation PCI, we have a feeling, we know that both clinical and lesion factors are important, but how can we integrate these two factors? To do an analysis on this topic, I used the Bifurcation registry, which is the largest bifurcation dedicated real-world registry. The abbreviation is the Noble Insights from the United RAIN and COBIS bifurcation registries. And this was a retrospective multi-center, multinational observational registry, which included 5,500 patients whom were treated with second-generation DES for bifurcation PCI. Just to give you a slight overview of the importance of a registry is that although the clinical evidence that we use in medicine is usually derived from RCTs, previous RTCs regarding bifurcation lesions have not given a concrete answer, but rather gave a aggravated confusion even for the simplest question, which is, should I use one stenting or two stenting for bifurcation lesions? The Excel, the Noble, the DK Crush studies all studied the same topic. However, the results were very different regarding this very simple question. So probably the real world registries, which has practical strong points compared to RCTs, may be a better registry, a study topic for the bifurcation PCI patients. So based on the bifurcation registry, we could see that based on the 5,500 patients, the mean age was 66 years old, hypertension was in 66%, DM was in 33%, CKD was in 13%, and the LV ejection fraction was about 58. Regarding the location of bifurcations, we could see that around 30% there were left main bifurcation lesions and 65% were true bifurcation lesions. For the 2-year clinical follow-up, the all-cause death rate was 4%, MI was 2.4%, and also regarding the composite endpoint, MACE occurred in 9%, and the hard outcomes, which we defined as death and MI, recurred in 5.4%, whereas the lesion-oriented clinical outcomes, which we defined as target vessel revascularization and target vessel MI, occurred in 3%. So for the feature selection of adverse clinical endpoints for MACE, we used the lasso regression model, from which we could select 9 features, 5 which are clinical and 4 which were lesion features. For abbreviation, we could see that old age, heart failure, renal disease, current smoking, and diabetes were clinical features, And for angiographic features, the left main disease, presence of proximal lesion, and presence of a side branch lesion, and the small main branch were angiographic features for MACE. So we integrated these 9 features into a single score, so-called the bifurcation score. And regarding the weight, these weights were calculated from the Cox regression model. We could see that the distribution of the bifurcation score was as follows. And compared to the lesion clinical features, the bifurcation score had an improved predictive value for MACE. However, going one step forward, we studied the distinctive predictive value for other outcomes, such as the hard endpoints and the lesion-oriented composite endpoints. Interestingly, for the hard endpoints, we could see that by the increase in the number of clinical features or lesion features, that there was a more superior increase in hard endpoints for clinical features compared to the blunt increase in lesion features. From this, we could see that for hard endpoints, the clinical features were more important. However, for lesion-oriented composite endpoints, we could see that the slope was steeper for lesion features compared to clinical features. Therefore, we could say that the importance of lesion features were more important in lesion-oriented composite endpoints. Also, we divided the population into 4 subgroups regarding to the high and low lesion risk and high and low clinical risk. And we could see that patients with a high clinical risk and low lesion risk had a higher event rate of hard endpoints compared to those with a high lesion risk and low clinical risk. This shows the importance of the clinical risk in hard endpoints. Also, for lesion-oriented composite endpoints, we could see that the event rate was much more higher in those with a high lesion risk compared to those with a high clinical risk, again, stressing the importance of lesion risk in lesion composite endpoints. So this is the conclusion of my speech. From a very large bifurcation dedicated registry, the BIFURCAT registry, we could select 9 features, 5 clinical and 4 lesion features that were important in predicting clinical events. These 9 features were integrated into a single score, the BIFURCAT score, which is very easy to calculate in the clinic. And interestingly, the clinical features were important for hard endpoints, while the lesion features were important for lesion endpoints. This is a quite obvious statement, but again, from this statement, we can stress that considering both clinical and lesion features are important in treating bifurcation PCI patients. Thank you for your attention.